Hello, good afternoon. I'm Dr. Prabha and I'm department in charge of Department of Periodontology. So here I am to demonstrate a procedure on ultrasonic scaling, and I have my assistant with me, Ms. Lojingi, who's about to help me. So we'll go about with the demonstration of scaling in the ultrasonic method of demonstration as well as polishing. Here you are having a model containing calculus, that is your false calculus, which we have placed with the acrylic. So you can see that the calculus is being attached on the tooth surfaces near the cervical aspects as well as the cervical aspects of all the molar incisor as well as molar teeth, and also you can see the aspects in the lowermost region also. So with this, when we are going to see about the plaque control and the oral hygiene index maintenance, we will be going about in checking with the help of a disclosing agent about your plaque. So plaque is considered to be a colorless material, so it is very difficult to view it clearly. So we need to have some disclosing agent to make us view it correctly. So we do have a disclosing agent where we apply it over the tooth surface. So this disclosing agent tends to help us to see or visualize the plaque better. So when the patient comes in, you will ask the patient to first goggle his mouth, and followed by which you will be placing your disclosing agent on all the teeth surfaces. So once this is done, leave it for 1 minute and then ask the patient to again goggle it. So when the patient goggles back again, what happens is that the area where the plaque is available, only those areas, if it is going to be a mature plaque, it is in blue in color, and those in immature plaque, it becomes pink in color. So that is to differentiate about your immature and your mature plaque and to visualize your plaque. Plaque, when it goes after some 2 to 12 days, it gets mineralized to form your calculus. Calculus forms as in modifying agent for your disease, whereas plaque is an initiating factor for your disease. So try to differentiate when a patient comes the difference between food debris, plaque and calculus. So food debris is something when you apply a water spray over your food debris, it tries to move away. Plaque being an organized structure as well as plaque being a biofilm structure is little difficult to get disorganized with the help of the water spray. So it is considered to be a biofilm. On the other hand, calculus is very difficult to be removed by the patient itself. For that, professional scaling has to be done, which can be done with either ultrasonic instrumentation or the manual instrumentation. Principles of instrumentation. So the principles of instrumentation remains the same for both the manual as well as the ultrasonic scaling. So starting with the accessibility. So whenever the patient comes, ask him to sit in the chair and make it into a supine position, whereby for the maxillary, when you are going to operate, have a chin up position, and for the mandible, when you are going to operate, have a chin down position. So you can see that in this case, the Nissen head is being fitted here, and in case of maxillary operation, I make it almost in a supine position, and for the maxillary operation, the patient is made in a chin up direction, and for the mandible operation, the patient is made in a chin down direction. Starting with the next principle, that is your visibility, illumination and your retraction. For visibility, you do have your light, wherein you do have your direct vision, whereby I see directly, or your indirect vision, wherein I use my mouth mirror to check my teeth or the calculus areas. So third being the condition and the sharpness of your instruments. So here I do have my 3 scalar tips. So I can explain you the scalar tips. This scalar tip, the name is universal scalar tip or tip A. So the name universal itself says that you can move into all the surfaces, including your smooth surface areas, your interdental areas as well as your subgingival areas. So this, as long as it permits, as long as your tooth or your gingival embrasures permit, you can go into almost all the areas. So this forms the other one is your smooth surface scalar. So you can see this is your tip B. So this is done on all the surfaces which has stains are there present on the smooth surfaces. This tip can be used, and certain tips called as piers or the interdental tips. So areas where it does not allow the entrance of tip A, you can go about with the use of the PS or the interdental tips. So this can be used on the area between the teeth as well as in the subgingival areas. Of conditioning of instrument, if you see your tip less than 2 mm from its original dimension, it is considered to be less efficient, less than 50% efficient, and is considered to be discarded. So if it is of the correct dimension, then it is considered that the condition of the instrument is good, and we go ahead with scaling of the teeth. This is your scaler tip. So your scaler tips, ultrasonic scaler tips, are of two varieties. One is the piezoelectric scalers as well as the magnetostrictive scalers. Mostly we use the piezoelectric scalers. So this comes with a frequency of around 85,000 to 50,000, the constant being 25,000. So this frequency is set by your manufacturer. Now coming on to the instrument, you do have 3 knobs here as well as 3 circuits here. So whenever you are going to attach your instrument, try to attach it at a single position without any twisting or turning, so that the circuits don't break inside. Alright, and so telling about the instrument, the pattern of movement of the tip in case of piezoelectric scalers is linear, and therefore the tip is active only in the lateral surfaces. To explain more about the tip when you are going to use in a piezoelectric surface is active only at the 2 lateral surfaces, and the most active area is considered to be the first 3 mm of the tip. So please be careful that you place, whenever you are going to place the instrument towards your tooth surface, try to place the lateral surfaces over your tooth surface, right. To attach the tip to the handpiece, I do have a wrench here, whereby I place my instrument into the tip, into the wrench, and then I screw the wrench to lock it. That's it, one lock. And afterwards we will be telling about the next principle called as the instrument stabilization. The grasp first. So we mostly use the modified pen grasp for your taking of your instrument or for your grasping of your instrument. This is the most preferred method. The reason being that the tripod effect acts on the instrument, whereby you can stabilize the instrument better. Better control is there when you are going to rotate the instrument, and sometimes in case of a hand instrumentation, when you are going to use a tripod effect, or you do have better tactile sensitivity also. So in case of your grasping your instrument, you use your modified pen grasp, and when coming on to the placement of the instrument in the patient's mouth, you have to take your extraoral fulcrums as well as your intraoral finger rest. You do have 2 fulcrums. One is your palm up, which means my palm is facing upward. So when I am going to step my instrument, my maxillary molars, I use my extraoral fulcrum, whereby my palm is faced up. So this is my palm up position. And when coming on to my other areas, like for example my mandible areas, I use my palm down position. So this is my extraoral fulcrum. Next, coming on to the intraoral finger rest. So there are 4 types of finger rest. So starting with the first finger rest is my conventional finger rest, where I do take support from the adjacent teeth, and in case of finger rest, I use my ring finger to place it on the finger, and I use my instrument to be placed in this particular notch, and my little finger to be closed like this. So in that case, I place my ring finger on the adjacent teeth, and when activating my instrument, I activate in this way. So this is my conventional finger rest. So certain areas I could not do this conventional finger rest. So certain areas, like for example the palatal second quadrant palatal aspect, I need to take a cross arch finger rest, where when I am doing my second quadrant, I use my first quadrant as my finger rest area. And when coming to certain other areas, I might also use my opposite arch finger rest. Like for example, when I am using my upper area, I am taking finger rest from my lower teeth. So this is opposite arch. The last finger rest called as the finger on finger rest, where we mostly don't use that particular finger rest when we are going to do our ultrasonic instrumentation, whereby I use my finger, reinforce my finger on my little finger. So this particular thing we don't mostly use for ultrasonic instrumentation. So this is about the finger rest placement and your extraoral fulcrum. So instrument activation, it has 4 different: adaptation, angulation, lateral pressure, as well as the stroke. So now coming on to the adaptation. Adaptation is how the tip or the working end of the instrument is conformed to the tooth surface. So try to adapt it as close as possible to the tooth surfaces. As I told you, only the lateral aspects are the one which are going to be active in this particular instrument. The lateral aspect of this instrument has to be parallel to the tooth surface wherever possible. Like for example, when I am going to use my labial surface, I place it parallel to the tooth surface. When I am planning to use it in my interdental surface, again I place it parallel to my interdental surface. Got it? With a horizontal stroke. So this is termed to be adaptation. When it comes to angulation, it has been found in case of ultrasonic instrumentation, either 0 degree angulation, the angle between the working end as well as the tooth surface is found to be 0 degree, or either 15 degree. Like I can give a 15 degree angulation like this when I am going to go in for my subgingival calculus or cervical calculus. And next is about your lateral pressure. Since most of the pressure is being carried out by the vibrations, so when you give a moderate amount of pressure only here, it is able to remove most of your calculus. That is, your ultrasonic instrumentation works on the mode or works on the principle of vibration. And next, coming on to stroke. So when coming on to strokes, I would be explaining only in terms of directions. So this is your vertical direction of stroke, this is your horizontal direction of stroke, and this is your oblique direction of stroke. So when speaking about mechanism of action of ultrasonic instrumentation, you need to know what is frequency, what is stroke, and what are the physiological effects of the water flow. So coming on to frequency, frequency is considered to be the number of times this particular tip moves when it is vibrating back and forth. So if it is moving in 1 second, how much it is moving. So it has been set by the manufacturer that it can move around 25,000 times per second back and forth like this. So you can imagine how much amount of vibration is there in this particular tip. Next coming on to the term called as stroke. Stroke is a term which is given for the distance how much the tip moves back and forth. Supposing if the tip is moving in this direction, if it is moving in a linear direction, so how much this distance is moving in the linear direction is termed to be stroke. So half this distance is termed to be amplitude. So hope you are agreeing, understanding all this. So if you have understood this, then I am moving on to the physiological effects of water. You have 3 different physiological effects of water. So the first being your acoustic microstreaming, where there is a unidirectional flow of water. So the water which comes out through the small nib which is here comes out in a unidirectional flow. So that is termed as your acoustic microstreaming. After your acoustic microstreaming, it goes on to the next step called as an acoustic turbulence, where the tip when it is accelerating in the coolant produces an intensified swirling effect, and it is called as an acoustic turbulence. So followed by acoustic turbulence, because of the turbulence effect, you do have bubble formation, that is called as your cavitation. So these bubbles try to implode within each other, causing more amount of bubbles, and these bubbles, when they touch your calculus, they try to explode, and when they are exploding, they try to break up the calculus from the tooth surface. So it has been found that these 3 effects of water, that is your acoustic microstreaming, your acoustic turbulence, and your cavitation, together has been found to disrupt the microflora of the tooth surface. Instrumentation, I do have a water flow like this. So you can see this feed getting, the amount of water being released is very high. So I reduce it so that my water is comparatively at this speed. So exactly when it is dripping, this is considered to be a correct stage of using your instrument. So whenever I am going to start with my ultrasonic instrumentation, I start from 1/8 to 2/8, I finish my buccal aspect, and then from 2/8 to 1/8 I finish my lingual aspect, 3/8 to 4/8 my buccal aspect, 3/8 to 4/8 my lingual aspect. Always try to follow a sequence of doing, or if you find that taking 3 teeth per time is being beneficial for you, for example 3 teeth on the labial side, so same teeth finish it on the lingual aspect also, and then go on for the next 3 teeth. So this is also one more method of doing your work. So now I'll start on with my 1/8. So when I'm going for my 1/8 region or my first sextant or first quadrant for doing, I go in for my maxillary extraoral fulcrum is my palm up position, placement of my instrument towards the tooth surface with an direct vision, direct illumination, and then I start to activate my instrument. And when activating my instrument, I do have two different types of stroke available. So I will be telling that stroke here in the anterior region for better visualization, wherein when there is going to be a plaque in this area, I just do a little deplaquing stroke in this mode, where I just sway my instrument towards the tooth surface. Whereas when I am having a calculus near the cervical aspect, I do a tapping stroke in this fashion to remove my calculus. So this is your deplaquing stroke to remove your plaque, and this is my tapping stroke to remove my calculus. So if that is the case, then we will go in for the same deplaquing stroke here. So I have retracted very well. So once I have completed this, I can also go internally. And I go for my next set of teeth. So you can see here I am taking a conventional finger rest from the or a cross arch finger rest when I am going for this, and I retract with the help of my non-operating hands finger. And when I am going to my second quadrant, I need to have an indirect vision and an indirect illumination with the help of my mirror. So I indirectly view it with the help of my mirror, wherein I go for when I am going to view my palatal, I need to go in for an indirect vision here with an indirect illumination. The reason being that we will have to take care of looking or viewing this area with our proper positioning. So when I am going for this this side of the tooth to be operated, I go in again for my finger rest to be placed on the conventional mode, and then I go in for operation, whereby after your scaling, we generally go for polishing. This is mainly to remove the irregularities which has occurred during the time of scaling. So you polish the surface, so this calculus which are stuck on the teeth, when we remove it during the process of scaling, tends to produce irregularities on the tooth surface. So by means of polishing, this tooth surface is getting smoothened. So that is the reason why we do polishing, and this polishing paste also gives a lustrous effect to your tooth surface. So it is always mandatory that after scaling you need to go in for polishing. This can be deferred in patients where they have little sensitivity, especially when the recession defects are very much severe. The polishing cannot be done in such patients, so that is one of the contraindications. Another one is like if it is going to be a newly erupted teeth or the primary teeth. So in those cases the enamel is little brittle, so we don't go in for polishing in those aspects. But most of the cases, once you have done the scaling, please go in for polishing. And your rubber cup, and along with that you do have a set of cotton rolls and your gauze pieces, and your micromotor which is fitted to your share. So when you are going to do your polishing, try to remove your scaling instrument first from your table, because there are chances that you get injured with this particular equipment, and then you are going to fit in your rubber cup to your micromotor. And while you are doing that, try to close in the water in the panel, the control panel. You do have a water placement. try to close in that and try to close in the water spray also completely. For polishing, I always take 3 teeth at a time. Like for example, I try to take my last 3 teeth. So I start with my last 3 teeth. I do my buccal surface, my lingual surface, my palatal surface, and then move on to the next 3 teeth. So when I'm starting with that, I first try to isolate this area with the help of a cotton roll. I isolate it with the help of a cotton roll. I dry that area with the help of a gauze, and then I place my polishing paste on each of these tooth surfaces. So to start with the procedure, I will explain the procedure first on a flat surface, wherein you have to place 2 horizontal lines. To imagine your vertical lines, 2 horizontal lines, which means there will be 9 different quadrants. To tell again, imagine this to be my tooth surface area, where I place 2 vertical lines and 2 horizontal lines. So I have 9 different quadrants here. So when I am going for my procedure with my micromotor, I go with a circular motion. So the first quadrant I have a circular motion, the second quadrant I have a circular motion. When I am going to do my second quadrant circular motion, this will overlap on this quadrant. So similarly, when I am going to go for my third quadrant, this will overlap on this area. So my fourth quadrant will overlap on my first, second and my fifth side. My fifth quadrant will overlap on all my sides. So same way you are going to do with the help of your micromotor, wherein circular motion, circular motion, circular motion, circular motion, circular motion. So all the 9 quadrants we are going to do. So that is the way we are going to do. So the motion which is being done here is your circular overlapping motion. I told you I will be dividing into 9 different quadrants. So I will be starting. Once you have fitted your rubber cup, try to check the speed limit with the help of your adjustment which is there down. So this is running at almost a very high speed, which will take out most of your tooth apparatus. So try to lower the speed at the lowest possible speed. With the help of the sound, you can differentiate the lowest possible speed and with the lowest possible speed possible. Okay, and then we go for application of the small size has to be taken. I have isolated my tooth. I place it on my tooth surface, and then I go in for my my first quadrant, my second quadrant, my third quadrant, my fourth quadrant, fifth, sixth, seventh, eighth and ninth. After finishing all of them, one single full hole. When I have completed my labial aspect, I go on with my lingual aspect as soon as I do that. So again I go with my first, second, third, fourth, fifth, sixth, 7 and 8 and one full. So whenever you are going to do this, try to be cautious that you are having either a pen grasp or a modified pen grasp with a finger as possible and the closure of your little finger. Alright. So to again reiterate on the most back posterior regions, try to retract your cheeks as far as possible so that you will be able to balance your teeth on the tooth surface. Right. So once I have done this, once the buccal side is over, I go on to my lingual side, wherein I again place my polishing paste. I take a finger rest to this side. When I notice there is going to be high speed, I try to reduce out my speed. Irrigate it with the help of a water spray so that I remove the polishing paste then and there. So then again I try to check if the area is polished with the help of a wet gauze. I just check and see if this area is polished then and there. Then I move to my next set of 3 teeth. Alright. So don't always try to run the instrument only when there is polishing surface on the tooth, polishing paste on the tooth. Don't run it on a rough tooth surface. You will land up removing most of the tooth enamel possible. Alright. Okay, so I think this is for the upper, so it's going to be the same on the other side. I'll explain it for the lower with the help of the lower aspect. Again, always isolation is needed for the lower anteriors too. I dry the surface with the help of my gauze piece so that there is no saliva on the tooth surface, and then I go about for placement of polishing paste on my tooth surface. Probably I'll explain you once more. I'm going to divide it into 9 different quadrants, and then 1, 2, 3, 4, 5, 6, 7, 8. So you can see my hand, there is a kind of circular motion in my hand. So I will give my circular motion to all these 9 different quadrants on the tooth surface. And same way, I take little polishing paste on this side and I give the same motion on the other side too. A circular motion followed, circular overlapping motion followed by a full circular motion to polish the teeth. So we are going to follow that for the maxillary as well as the mandible. Once the polishing is done, you do have polishing material which is left out like this. So always try to clean it then and there with the help of a spray of water, or after the spray of water, you can always try to clean it or check for the lustrous effect with the help of the wet gauze piece too. At the end of the procedure, when you are going to instruct the patient, telling the oral hygiene instructions, ask the patient to go home and brush his teeth, because these polishing paste contain more amount of abrasive particles which tends to seep inside the gingival clavicular area. So it's always better that the patient goes and brushes.